Hello and good morning, everyone out there in webinar land. My name is Jeff. I'm the director here at Insight, and it's my great pleasure to welcome you to today's webinar. Firstly, I will acknowledge the traditional owners of the land on which we're gathered here. We're in Brisbane in Meanjin, on Turrbal and Yagrala land, and pay respects to elders past and present. We'd also like to recognise people with a lived experience or living experience of mental illness, suicide, and substance use as the reason why we're all here, and the role of parents, carers, and significant others in their personal journeys. It's my great pleasure to welcome Dr. Kathryn Turner to present today's webinar on the topic of paradigm shift in the way we work with suicide and self-harm. Dr. Turner is the Executive Director here at Metro North Mental Health here in Brisbane. And so without further ado, I'll throw it over to you, Kathryn, and thank you for today.
Welcome to everyone. I'd also like to acknowledge the traditional owners of the land on which this meeting takes place and the many lands, and I pay respects to all elders past, present and future, and acknowledge Aboriginal and Torres Strait Islander peoples across the state. I'd also like to recognise the lived and living experience of people with mental illness, problematic alcohol and other drug use, as well as those impacted by suicide and trauma, their families, carers and support people. We respect and value their opinions and input into service delivery and change. So today I was going to talk a bit about some of the challenges that have sort of been present in suicide prevention forever, and really the need to move and a shift in paradigm. So and looking at sort of both individual approaches, which is what we've predominantly seen in the sort of particularly in the health system, and also population-based approaches. To support that, I'm going to talk through the paradox of suicide prevention and how that helps us to explain some of the paradigm shift and some of the complexities of suicide, self-harm and overdose, and sort of talk through some of the reasons of why we have developed a sort of framework where we're trying to combine multiple components. When there's a paradigm shift, there's always, or when we do anything new, there's always a risk of unintended consequences. So I also want to present some information that I guess is a bit of a caution about some of the change in paradigm and how we might be able to, what we need to be aware of and address. If we've got time at the end, I was also going to talk a bit briefly about a paradigm shift in learning from harm in our systems as well, and restorative just and learning culture, because I think it's always important whenever we're talking about suicide prevention that we also talk a bit, particularly some of these paradigm shifts, that we also talk about the importance of a restorative just and learning culture alongside that. So, why do we need a change in paradigm? Well, I guess there's a whole lot of issues that have sort of plagued us for a long time, and really, I think many clinicians we've known for a long time that our current approaches were not working particularly well, and we needed a shift. So we're stuck. We've been stuck in a risk prediction approach, imagining that we can predict suicide, but we'll talk through why that's actually impossible to do. We've also traditionally used diagnosis as a gateway to treatment, and yet we know that many people that die by suicide do not necessarily have a serious mental illness. So, you get this, similar presentation. So distress arising from, for example, loss, grief, frustration, humiliation, defeat, entrapment, and childhood adversity, leading to suicidal feelings. If you've got the similar sort of presentation but a diagnosis of mental illness, you were traditionally eligible for health service support and mental health service support, but without that diagnosis, often not. Or if you simply had, or if you had a diagnosis of mental illness, that would be the gateway, I guess, to services. But we need to understand, why that's actually not going to get us very far in terms of suicide prevention. We've also had a very big focus on assessment as an end in itself, rather than actually providing skills to clinicians to provide interventions as well. or for services providing interventions. So there was a huge focus on, risk assessments as the sort of main focus. There's also a lack of integration of training to support local pathways. So training was often sort of piecemeal. It didn't necessarily connect, well to, the clinical setting as well. And there was also a general pessimism about our ability to prevent suicides. So, statements like, well, you could never have predicted this, or alternatively, it was inevitable, or if someone is determined to die by suicide, there's little that we can do. But I guess, we challenge some of this. And I think some of the pessimism and defensiveness was a defense against what we knew were impossible, expectations on clinicians to be able to predict. And I think that, we wrapped around a lot of defenses around ourselves for that. So, and while you can't predict, that doesn't mean that you can't do a range of things that can help prevent suicides. So there was also really a lack of a consistent approach to support for staff following incidents and for families, and also concerns about a culture of blame or limited learning from incidents. So really reliant on outdated safety one principles and very linear approaches to learning, which which just sort of reinforced the whole risk prediction approach. And the processes are highly influenced by hindsight and outcome bias, and they fail to really understand and incorporate our understanding of complexity in our systems when we're reviewing incidents. So if I just talk through, some of the issues around that, have frequently been present, I guess, the way that we view things. So we consider that there's people that are high risk to going on to die by suicide. So we assume that it's those people that are high risk are the people who die by suicide. Therefore, if you died by suicide, the assumption is you must have been high risk must have been in that high risk category. So, but if you weren't identified sort of before, if you were seen before that suicide and you weren't identified as high risk, we've assumed that we must have missed something. The clinician must have sort of made an error either in their assessment or their actions. They should have, if you look back and you can see all of these risk factors, very easy to see in retrospect. So, our assumption is, well, if we just assess better and, do our risk assessments better, we're going to identify those people that are going to go on to die by suicide. So we need to prevent clinicians from making the same errors. We need to train, do better risk assessments, improve our management of high-risk individuals, improve policies and procedures around high-risk consumers, and we think that that will have the greatest impact on preventing suicides. And we know repeatedly over years, that's the sort of responses that we've often had to incidents when reviewing suicides. Now, a recent Queensland study, sort of based out of Metro South, looked at 68 SAC1 suicides between 2014 and 2016. So these were either people currently being seen by a mental health service or seen within the last 30 days. And they had a look at whether they had a risk assessment completed, and about 70% of them had. And they found that 75% were classified as low risk and none were classified as high risk. So the question is, how could our clinicians, how could we be getting it so wrong when we're assessing? So clearly we must be missing high-risk consumers. So I think, there's a range of explanations for it, including, our linear approaches to learning, confirmation bias, hindsight bias, and outcome bias. So if we look at, now we do know that there are a group of people that have a very high risk of dying by suicide. So there's no doubt that, so if you've got a sort of combination of high lethality attempts, so this is a Swedish National Register study. So, the Swedish do these fantastic, very large scale reviews, and they looked at, 48,000 individuals admitted to hospital after an attempted suicide. And then they followed them up for 21 to 31 years, and they looked at who died by suicide. So they found that if you look at the group of people that have very high lethality attempts, that approximately 55% went on to die by suicide, and 87% of those in the first year. If you combined the high lethality attempts with a mental health diagnosis, such as psychosis, 84% died by suicide during follow-up. And if you had a lower lethality attempt, such as self-poisoning, only 2.7% died by suicide. So, well, that tells us that surely we must be able to predict there's people that are in a category that if we assess appropriately, we will know that they're a very, very high risk of going on to die by suicide. So but what we know is that, 83% of people were actually in that lower lethality attempts. So they made up, even though they had a much lower risk of dying by suicide, they made up the majority of deaths by suicide, 74%. So although there are definitely high-risk people, and we do need to understand that and address that, if we just address that, we will miss most people who will go on to die by suicide. So this is taps into the concept of the prevention paradox. And Jeffrey Rose talked about this way back in 1981, and he looked at things such as sort of, say, alcohol use. We know that most morbidity comes from people not necessarily at the high risk, but at the moderate risk, because most of the population, most of those at risk are in that moderate group rather than the very high risk group. So if we apply that to suicide prevention, most suicides come from lower category due to their larger numbers. So, and that's paradoxical, because it's common to assume that those at high risk will make up the majority of the burden of disease, and we engineer our whole services around that. We absolutely have traditionally engineered our mental health services around that, and our incident reviews around that. So tapping into that prevention paradox, we know that we really need systems approaches rather than a sole focus on individual risk. So we need to both focus on individual risk, because clearly there are some people who are very high risk, and we need to address that. But also more population-based approaches as well. So we look at that larger population and what we can do to intervene to make a difference for people that are actually going to make up most of the suicides. So, and we do that, and I'll talk through this through what I think Jeffrey Rose called structural prevention efforts, which is such as implementing a pathway of care, so our suicide prevention pathway. So an example of this would be that, say, all hospital-treated self-harm would be provided with an intervention, regardless of any individual risk. So you might individually assess someone who's taken a sort of minor overdose and say, well, they're fairly low risk. But actually, what we'd do is we'd say, well, actually, anyone that has had a self-harm attempt as a population, they are going to that's probably the most significant risk factor that we could look at. So if we provide all of those people with at least some intervention, then we're likely to have a greater impact on the total number of suicides that we can prevent than just trying to identify those at high risk. So it's probably not as simple as that in terms of what's the reasons for who went on to die by suicide that were rated low in the majority. So I think the paradox of prevention explains some of that, but also I think there's a range of other things that explain it. I think we get incredibly desensitized to risk. We frequently say people are low risk, but there's probably very few people that would come through our emergency departments, for example, that would be low risk, and for a range of reasons they're significantly higher than the general population, but we've become desensitized to this, and there's ways sort of addressing this. We also know that suicidal ideation is intent is fluid, so it fluctuates. They may well have had expressed no suicidal ideation at the point of discharge, but a range of events can occur that can rapidly escalate their risk and their ideation and intent. There's also, I think, a pressure to label someone as low risk if the decision is to discharge them. Whereas, what we know in suicide prevention is that that might be absolutely, even people with a range of risks, that may be absolutely the right thing to do to discharge them, but address and mitigate those risks in the community. So a pathway of care, which I'll briefly talk through in due course, can address all of these issues. So if we look at some of the data, and this is sort of taps into why we think that you can't just look at suicide prevention in isolation. There's a whole lot of interrelationships that we need to sort of be clearer about. So we know that in 2020, there were about 791 suicide deaths in Queensland. 77% of those were male. And that's probably, we haven't traditionally talked about that a lot, or engineered our services, or looked at how we can address, the fact that the majority are males. And that's not just in Queensland, that's a consistent finding. So there were about 28,000 hospitalisations due to intentional self-harm in Australia in 2019-2020. The suicide risk following hospital-treated self-harm is 49 times that of the general population. So it's a big, a significant risk factor. And repetition of hospital-treated self-harm may be reduced by 40% when treatment includes a thorough psychosocial assessment. But we know from a recent Australian study that probably only about 60% of people are receiving a comprehensive, who present with self-harm, are receiving a comprehensive psychosocial assessment, and only about 50% are actually getting any interventions. Overdose, about 74% of drug-induced deaths were unintentional. About 2/3 of drug-induced deaths are male. And for every overdose, there's probably 30 non-fatal overdoses. We also, intentional, was it intentional? Was it unintentional? We know that there's sort of this intentionality continuum. And there's this overlap between substance use and suicidality, sort of some common, determinants, physical health, behavioural problems, trauma, adverse child experiences, social isolation, etc. And we know that there's some overdoses that are clearly intentional, some that are clearly unintentional, and then there's sort of a group in the middle that is both very hard to sort of differentiate from an external point of view, but also from the individuals. So there's sort of a description of an experience, the depths of despair that people feel in despair, and whether it was accidental or non-accidental is not really clear, even to the consumer themselves, client. Aboriginal and Torres Strait Islander, we know that they are vastly overrepresented in all of these issues. So they have a suicide rate of 27.9 per 100,000 versus non-Indigenous of 14. Aboriginal and Torres Strait Islander people have 2 times the intentional self-harm of non-Indigenous, and they're almost 4 times as likely to die from an unintentional drug-induced death. So clearly we need to look at how we specifically address Aboriginal and Torres Strait Islander peoples. So why do we need to address, so we're proposing that we really need a framework that addresses suicide, self-harm and overdose together. Why do we need to do that? So some of those statistics sort of reinforce that. So we know a personal history of self-harm was the most frequent psychosocial risk factor for both intentional and unintentional deaths from overdose. A non-fatal overdose is associated with both future fatal overdose and future suicide. And co-occurring disorders are the expectation, not the exception. So we need more holistic approaches, looking at mental illness, substance use, physical comorbidity, including persistent pain. So we need more integrated approaches to care, which we've been talking about for a long time, but seems to be challenging to deliver. And there must be a significant focus on suicide, self-harm and overdose to achieve health equity for Aboriginal and Torres Strait Islander peoples. So I think it's really important also to look at to hear from a consumer perspective as well. So Michelle Sanders was our Director of Recovery for the past 12 months at Metro North. So she's sort of leader of our lived experience workforce and brings both a consumer and a carer perspective to these issues. So she's going to talk a little bit about why what we call our framework Aspires, and it's a suicide, self-harm and overdose sort of prevention approach. So I'll just play this, hopefully it'll work.
I'm excited about the Aspires program because it, rather than focus on just one part of, difficulties that people experience around suicidality, it actually is willing to take on the true challenges that people face. It's never just as simple as having a program that will look at suicidality or something that seeks to support people with their substance use issues, or seeing self-harm as a set of behaviours related to distress, that all the complexity of those actually in people's lives and their families and carers is the reality. Previous approaches which might try to simplify things so that they're easier for us to try to implement are ineffective. And so rather than do that, we've recognised that actually we need to challenge ourselves to take a sophisticated approach which actually is not going to shy away from the complexity of the situation, and that we're willing to do the really hard work of seeking to understand the really complex interplay of all these factors for people, and then going further than that to seek to actually address that. It's a really big aspirational goal. Let's try to support people to overcome suicidality, to save lives, to reduce distress that leads to self-harm, and also the impacts of substance use on our community.
Okay, so I guess the framework, so how do we incorporate that sort of understanding of the paradox of prevention into how we approach, how we respond to people who are presenting with suicidal crisis? So, if you conceptualize that, the whole group who might be presenting with distress, suicidal crisis, suicidal ideation, intent, behaviour, or self-harm, and there's that sort of broad group that are probably a lower risk, but the opportunity to intervene with larger numbers. And then there's that smaller, higher risk group. They are definitely higher risk, but there are lower numbers, and that might include people with mental illness, co-occurring substance use and physical health disorders, and high lethality attempts. So the Jeffrey Rose, this is from Jeffrey Rose as well, talked about the bell curve shift in population. So this really just sort of describes how we intervene with this understanding about the paradox. So traditionally, we've sort of focused on that high risk population and moving that high risk population to the normal range of risk. But actually, if you address and intervene with that larger sort of moderate group, higher than normal, and shift them to the lower risk, you're actually going to be addressing a lot more, many more people. So, so in terms of sort of, I guess, population-based approaches, we can talk about I can talk about universal, selective, and indicated interventions. So our use of these terms is probably a bit of an adaptation of the broader all of community population-based approaches, but I think the concept is similar. So you've got a broad population, and that's all of those presentations in crisis, and that all of those people are to receive selective intervention. So as a pathway of care, such as, the importance of engagement, comprehensive assessment, including assessment of risk and protective factors, importance of engagement with families and significant others, identification of needs through collaborative formulation, And I think that's a shift. We need to be shifting away from thinking about risk assessment to needs assessment. Planning, safety planning, including counselling on access to lethal means. We know that does lead to a significant reduction when delivered with high fidelity in people representing with suicide attempts. Individualised care planning, rapid follow-up and warm handovers of care. And, if we're able to, brief suicide-specific interventions such as CBT or this ASIP approach, which is another brief sort of intervention. And also we've got things set up like non-clinical aftercare, the way back support service is an example of that. But then there's a group that we do need to provide more interventions to as well, sort of in identifying that high risk subpopulation or the need, certain needs. So, and that might be, evidence-based treatment for mental illnesses, substance use disorders and other comorbidities, specific psychological interventions for subpopulations. So we know DBT is an effective intervention, closer monitoring and clinical care for high risk populations, such as people with psychosis or severe biological depression with vegetative, psychomotor or psychotic features, high lethality attempts, comorbid substance use, persistent pain, for example. So that's I guess on the right. So we've got it on the right is our Aspires pathway. Sort of up the top is sort of, I guess, the introduction of who might be in scope for that. So all existing and new service users presenting with risk of suicide, including all presenting with self-harm, suicidal and non-suicidal, and overdose, intentional and unintentional, will receive a comprehensive biopsychosocial assessment. Engagement with the person must honour their dignity and embody compassion and respect, as well as incorporate the principles of trauma-informed care and culturally responsive practice. And the aim of this is to support the development of a strong therapeutic alliance. And then the pathway sort of addresses all of those things, and we don't have time to go into, won't go into that in detail, but it sort of incorporates a pathway of care where we train and provide enhanced skills for clinicians right across the service to provide some to have a shift their approach to risk assessment away from that risk prediction approach to a formulation-based preventive approach through the prevention-oriented risk formulation. Some enhanced skills to look at how we can better identify suicidal intent, how we pull all of that together into an integrated formulation, and then how we provide brief interventions for all of that population. So safety planning intervention, counselling on access to lethal means, brief information and education with the consumer and their carers, and also for, where appropriate, brief substance use intervention as well. So if everyone in that broad category gets those, and then there's a decision point about who might require more intensive follow-up as well, and specific interventions. So, and I guess just as an aside, sort of, it's certainly in Metro North, we're implementing Aspire. So at the moment, we're sort of training up, aiming to train up hundreds of people, and we're sort of well on the way. And then we'll have a sort of go live date for the implementation of this pathway. But we've certainly had involvement with the pathway previously. So not Aspires, but more of a sort of looking at suicide prevention pathways. So we implemented something similar to that at the Gold Coast. And what we were able to demonstrate is if you put in a pathway of care with good fidelity, and we support clinicians with training to be able to do that pathway of care, then we found that we had a 35% reduction in suicide reattempts. And really interestingly, all populations benefited in a similar way. So people with one presentation or more than one presentation, all age ranges, Indigenous and non-Indigenous, and also a little bit surprising to us, people with personality disorders also benefited significantly from this, this approach. So previously we had focused on that high risk population, but then we broadened out the population. So we saw on our pathway, I think it was over the 4 years, almost 7,000 consumers had these, were placed on the pathway and had these interventions. And I'll talk a little bit more about the risk, so the unintended consequences. But I guess we've got some data here that shows that, you've suddenly got, more people in scope for at least brief interventions, and our systems are actually engineered for that, and it can place some extra pressures on the system. And what we found is that as our numbers went up, when there was peaks, then our fidelity to the pathway reduced, as you might expect, and the fidelity were really on the most evidence-based interventions, which obviously is a concern. So how do we address this? We know that this pathway can significantly improve outcomes, so we do need to think about how that's supported. Okay, so, and just, I guess, the concept of a mental model. So we think this is the paradox of prevention is a useful mental model to keep in mind for a range of reasons. I think from an individual clinician level, we often, it's hard for us to shift away from the idea that we can't actually work out who should be in scope for service and who shouldn't, and we're not very good at sort of following a pathway necessarily in medicine. Certainly, if I can say, doctors aren't particularly good at it. I think people feel that their sort of clinical autonomy is challenged. And I think this, what we're saying is that for at least a broad range of consumers, it doesn't matter what the individual risk might be for all people presenting, say, with self-harm, we will still place them on the pathway because we know that paradox of prevention tells us that's the reason why we need to. So, that mental model, I think, is useful for us. It's also really important, to get that mental model, from a hospital and system perspective. So how do we re-engineer our pathways in services and to support this broader population-based approach? And also, it's important from a planning perspective. So the National Mental Health Service Planning Framework, we know, doesn't actually even address suicidality, let alone paradigm shifts in suicidality. So we have talked to the people that do, create the National Mental Health Service Planning Framework, and they presented some of this data as well. And they've had others sort of, I guess, advocating, and they are doing some work this year to look at least suicidality and how we can better plan in our frameworks and funding for services. So I guess just to summarise some of the drivers for change, and I've probably gone through most of this. We need to, acknowledge the limits of our prediction of suicide, as I think it's Matthew Large says, we need to acknowledge that to our patients, their families, and healthcare system providers. There's a range of reasons why most suicides occur in those deemed low risk. We need to understand that and therefore move from a risk assessment to a needs assessment type of approach. We need to move away from a diagnosis as a gateway to treatment. We also, need to not only treat the mental illness in the crisis, but treat suicidality directly. And, some of those interventions that I talked about are treating the suicidality directly. We need to challenge the nihilism and pessimism. And we need to focus on we need to shift away from that focus on assessment rather than intervention. And we need to integrate our training so that if we develop a pathway, then the training needs to support that. And also we need to, and we haven't talked about this much yet, but we need to challenge the culture of blame and the inconsistent support for staff and families and the linear safety one approach to learning. And we do that via the restorative just and learning culture. And why aspires? Why have we got that sort of suicidal self-harm and overdose? Again, we know that self-harm is not only a predictor of intentional death, but also unintentional overdose death as well. Non-fatal overdose is associated with both future suicide and non-intentional overdose deaths. We need to understand that, co-occurring disorders are the expectation, not the exception. We need more integrated approaches to care. We need to address the significant increased risk for Aboriginal and burden for Aboriginal and Torres Strait Islander peoples. We need to get away at someone sort of to use this term, and I thought it was a great term because I think it really challenged what we've been doing. And that they talked about gender blind services, and I think we have been gender blind in our services. I think we've often thought that males don't come to care or treatment, but actually probably there's more evidence that they do, but we don't continue to engage them. So what do we need to do? And there's some work across Australia that's some great work that's looking at how we can improve engagement of males in our services. And there's other groups such as LGBTI and culturally diverse older persons, etc., that need specific approaches. So trying to sort of incorporate that into our aspires. So before I go on to some of the unintended consequences, did anyone have any questions? So I think there were a couple of questions that came through.
Kathryn, there was a question around, I guess, through the pathway, there is an assessment of suicidal intent. And does that bring risk assessment back in when we're trying to do more prevention focused? So
yeah, so I think the assessment, so often it's not about prediction, but it's about how we can address the needs. So identifying, so the case approach chronological assessment of suicide events helps to support clinicians. Often, we're challenged when people say come in with, what certainly appeared to be an overdose. By the time they get through the ED and get to talk to mental health, they said, look, it wasn't an overdose. I didn't mean to do it. I just wanted a bit of sleep, just took an extra couple of tablets. How do you get beyond the stated non-intent to really understand whether there is intent there? And then that opens up a conversation about what sort of thoughts there have been and what sort of ideas and methods have people been thinking about, and then how can we actually address those through counselling on access to lethal means, and very specifically mitigating those risks. So it does lead to sort of actions as well, but we're not saying we're going to predict risk. It's more about how do we understand and then intervene and provide mitigations, etc., and care.
I can answer the training question online, so you can proceed.
Okay.
Now. And nice comments around how the pathway is awesome.
Okay. Thank you. So, so now the next bit again. So it's Michelle Sanders, who, as I talked about before, was our Director of Recovery and a really strong advocate for consumers and carers, within our systems. And we've put together a bit of a video which I guess tries to tap into some of the concerns that we've got around, sometimes you throw the baby out with the bathwater when you get new ideas about things. And there's still lots about the old approaches and lots that we know about sort of mental illness, etc. That means we still need to provide, care for all consumers. Anyway, I won't talk more, but I'll leave it to, so there's a bit that I talk about at the beginning that sets it up, and then Michelle talks about her, concerns about the unintended consequences.
We've seen important and necessary shifts in paradigm in our suicide prevention efforts. Services used to focus on seeing suicide as resulting from mental illness. We'd often use diagnosis as a gateway to care, seeing only those who had a mental illness diagnosis as being in scope for our services. We focused on treating the mental illness, and then the suicidality would be addressed through that. However, we recognised that many people who died by suicide did not necessarily have a mental illness or were high risk. A move to a more systems approach to suicide prevention addresses these issues. Our suicide prevention pathways do not use diagnosis as a gateway to care. People presenting in suicidal crisis without mental illness are in scope for the pathway and at least brief interventions and connection to aftercare. There are many social determinants and stresses which can contribute to people becoming suicidal. A great deal of change and services are now being set up for this important non-clinical crisis care and non-clinical aftercare. The problem with paradigm shifts is that sometimes there's adoption of the new ideas as an alternative to the old ways. What we need is a more nuanced approach where adopting the new ideas does not invalidate the important parts of our previous approach. In addition to seeing suicide as a crisis to respond to with suicide-specific crisis resolution and non-clinical aftercare, we also need to recognise that we must still robustly diagnose and treat mental illness when it's there. We know that those with mental illness have a much higher risk of suicide, and we must diagnose and provide appropriate clinical care for this population. It's important that this group receives both the population-level approaches and individualised care and treatment for their specific needs.
The unintended consequences of this shift in paradigm, where there has been important, robust advocacy for those in suicidal crisis who do not have a mental illness, is that people with mental illness can be portrayed as in some way different and separate from those needing crisis support. This can sometimes lead to prejudice and discrimination against people with mental illness and a sense of othering of those diagnosed with a mental illness. We need to bring this to the surface and promote community compassion, inclusion and acceptance of all people. The risk of an ongoing differentiation of those with mental illness and those without is that it is likely to increase stigma and discrimination and exclusion of people with a diagnosis of mental illness from the compassionate and soft, welcoming approach and language that is being promoted for others affected by suicidality in the community. It also does not make sense from many perspectives, especially from a young person's perspective, when suicidality may be high, but no diagnosis of mental illness has yet been made. As a person who survived suicidality when a young person, I know that an actual diagnosis was not made till years later, after many different personal and social crises and associated mental health challenges. Having a mental illness does not prevent people from experiencing the same stressors and crisis situations as anyone else in the community. Nothing in the realm of suicidality, mental health challenges and community response is simple. The interconnections between suicidality, emotional, mental and social crisis and mental ill health are complicated and multi-layered and influenced strongly by individual and group experiences and frames of understanding and the context in which we choose to approach the issues. We will need the approaches addressing suicidality to be sophisticated, multi-layered and inclusive. There are no simple ways of understanding suicidality and/or mental ill health and individual and community healing and recovery. Some community suicide prevention groups focus on trying to identify, amplify and justify differences between those who have been diagnosed with mental illness and those who have not, rather than the far more plentiful similarities between us all. Othering and discrimination needs to be challenged whenever and wherever it occurs. Even those of us with lived experience of surviving suicide and or being bereaved by suicide need to be challenged. We need to welcome varying perspectives. It is essential that we have ongoing dialogue together in order that we all learn more to help ourselves and our communities. During Mental Health Week this year, our Mental Health Commissioner encouraged us all to focus on the similarities, not the differences, that connect us to others, and also said that the importance of kindness and compassion cannot be overstated. I would agree with him.
Okay, so anyway, if anyone's got any other questions, and I'll try to answer the questions from Lisa and Jasmine. So Lisa has asked, can the public be trained to assist furthering this conversation with GPs? And also, Jasmine, is there room for the model to operate in non-clinical settings, or is it only in clinical settings? So certainly I think it's really important that we are speaking the same language. So and people, so we certainly have broadened it out in both the Gold Coast and here to some non-clinical staff. So certainly our peer workforce, our lived experience workforce, will receive the same training as this. and also the way-back support service staff. We'd be keen to, who are non-clinical staff who follow people up in the community and provide non-clinical support, to get this training, not to necessarily, sort of use all the clinical interventions, but I guess to understand the paradigm shifts and to speak the same language. And certainly something like safety planning is not something that just has to be done by clinicians. And there are ways that people can do that, themselves or with support, etc. So, but we are also keen for it to be very much as an intervention, a clinical intervention as well. So we did some training across with some of the private allied health, sort of psychologists, etc., in the community at the Gold Coast, and I think it is important to sort of introduce some of these ideas more into primary care as well. So it's at the moment in Metro North, we're focusing on sort of those groups, non-clinical groups that I mentioned, and also our clinical workforce, get as many people trained as possible, but also looking at, I think we would be keen to look at how we can have shared training across the whole region. Any other questions before I go on?
I think that's it for now, Kathryn.
Okay, so I was just going to talk now about so some of the issues around, if I can get this moving. Oh, sorry. Some of the issues that I've touched on before, and it won't be sort of a lengthy description, and I'm happy to have a chat at some other time in more detail about restorative justice and learning culture, because I think it's a really important move that we need to make. So why do we need a shift in paradigm in the way that we respond to harm in our systems and learn from harm, etc.? So we know that there are flawed systems of learning after harm. So if you look at statistics in healthcare, we've had this whole sort of whole process around patient safety, etc., and how we respond to incidents and how we try to make our services safer. But there's not a lot of evidence that there's actually been an improvement in healthcare harm for, Jeffrey Braithwaite would say, for the last 50 years. And certainly it seems to be stubbornly persistent at about 10% despite. So there's probably been some really good advances in some approaches that are quite sort of complicated rather than complex, and more straightforward. But in our complex worlds, which we're often in, there hasn't been a lot of improvement. So we work in complex adaptive systems. So that means that we've got a whole lot of interacting parts in our systems. A whole lot of humans interacting with machines and other parts of the system. And what we know is that in complex systems, both safety and harm sort of are emergent properties. They emerge from those complex interactions, and often it's hard to predict those outcomes. So we need to really understand the whole system rather than one individual's part in that, because when we look at one individual's part, we usually look very proximally, both in space and time, to the event, and fail to look at the whole system that actually enables, either supports safety or puts barriers in the way of safety. So if we focus on individuals, we will never understand exactly what is harmful in our systems and how we need to make systems changes. So it might feel like it's expedient, and we need to, people talk about we need to hold people to account, but we're really going to fail to learn the right lessons. And as I said, the system will remain unsafe if we do that. So it's really kept us stuck in those harmful, unhelpful or harmful approaches. We also compound our current systems. There's some, great sort of work, particularly out of New Zealand, with Jo Whaling and her team, looking at compounded harm. And we see it all the time, I think, that when incidents occur, our responses to them, or lack of response, etc., can often compound the harm for consumers, for carers, and for staff. We need, systems approaches to learning that take complexity of our systems into account, with the aim of sort of understanding that these are humans and relationships, and we need to heal first and foremost, as well as coming together to learn and improve. So it's a shifting away from, you know, the idea of let's hold people to account and looking back and trying to work out whether someone should be blamed or not, to actually looking forward, what they call a forward-looking accountability, which is actually a very deep accountability where we all come together and hold ourselves to account, I guess, for being part of a healing process, truly understanding and being open and feeling safe to be part of a good learning process where we truly understand what happened and why, and then hold ourselves to account in a forward-looking way, again, for how we improve the system, how we take those learnings and actually be part of the improvement processes. So, and that's sort of restorative, just and learning culture. So, you know, as I said, it's a significant problem. Current approaches are not working. Our responses to harm compounds harm, and we really need to do something different. So the restorative, just and learning culture, so the restorative approaches are not new. They've emerged from First Nations people, including Aboriginal and Torres Strait Islander peoples, who had the application of restorative practices and then also the application of restorative practices in fields such as criminology, sociology. There's a lot being used in education in Australia, for example, sort of youth justice, child maltreatment, and most recently in healthcare. And the concepts of responsibility and accountability to community, relationship repair, family and community decision-making are essential parts of First Nations processes used to resolve conflict and to respond to incidents of harm. So there's a great deal that we can learn from First Nations peoples about these restorative approaches. And also, you know, restorative approaches are important for the healing. You know, I guess just as a side, you know, healing for those issues with Aboriginal and Torres Strait Islander peoples and, you know, working towards health equity. So it emphasises, restorative, just and learning culture emphasises the central role of interconnectedness through a web of relationships and respects, which supports balancing concern for all parties when responding to conflict and harm. So we know that, you know, the consumer's been harmed, the carer's been harmed, but also looking at how other people sort of involved in that have been harmed as well, and how we can respond to that. And a restorative organisation develops policies and practices that recognise the needs of its staff or clients as whole persons, exhibits a distributed style of leadership and inclusive decision-making, and develops a culture of belonging and respect through the organisation. So how we do that, and restorative justice, so we've got those restorative approaches, then restorative, just and learning culture really, and restorative approaches can be used in a range of, are used in a range of things, but if we talk about restorative, just and learning culture, that's really that restorative approaches merging with our understanding of learning and improvement in our complex systems. So we're working in complex adaptive systems, we need new systems approaches to learning. And it's both a proactive approach of setting the safety culture. So what can we do as a service, as an organisation, as a community to set the culture before something actually even happens? And then it's about our response to harm in our complex systems and that forward-looking accountability, looking at you know, who has been hurt, what are their needs, whose obligation is it to meet those needs, and how can we prevent it from happening again? And it's really, you know, there's no cookbook, you know, menu that we can just follow to implement restorative just culture. It's a relational process and requires lots and lots of conversations, reflection, and co-design from all stakeholders. So I won't talk about complexity, safety 1 and safety 2, or any of this in much detail. But there are, you know, some great resources. So Sydney Decker is a professor at Griffith Uni who's written a great deal about safety differently, you know, safety in our complex systems, and also about, you know, the concept of second victim. We try to avoid that terminology, but, you know, that includes those that have been impacted other than, you know, the consumer and the family as well. And there's, if you're interested in, so Sydney DECA was certainly a strong influence in challenging my thinking, I guess, a number of years ago, around our current approaches to safety, and has been, so certainly I've been very interested in his work, but there's a whole lot of other people that are working in this area as well. There's some great, if you want to look at some of these, there's a field guide to understanding human error. There's a series of about 5 videos that you can get on YouTube where Sydney DECA takes you through some of these concepts. So now we've developed a framework within Metro North to look at, what are all the components, how can we look at those restorative questions, if you look at the diagram at the top, at the centre, and then how we have a healing process for families and consumers, but also staff, how we have a good learning process that engages all stakeholders and embeds safety too and resilient healthcare, and how we look at improving our improvement processes as well. So, and there's sort of a bit of a matrix at the top. We've got, in that diagram at the bottom, we've got that setting the safety culture, building respect and trust, learning, systems improvement, resilient healthcare. So what can we do as a system before an event occurs? And then looking at who's hurt, what are their needs in that matrix, how can harms and relationships be repaired, and how we can prevent it from happening again. So there's a whole range of actions that we take, or approaches that we take taking as a service, and gradually embedding these to address, to align with this. But as I said, there's no perfect, there's no clear manual for how you do this, and it's very much a sort of, as I said, a relational process. So I think, there's those diagrams that I talked about. So there's lots more that we could talk about restorative just culture, but we don't have time today. But I'm happy to put a couple of minutes left if there's any.
Yeah, Kathryn, there is a question from the Lodge, which is the Youth Residential Service in Brisbane North, about perhaps an incident where a worker was told that presenting at hospital could increase risk, and if there's any evidence around that particular situation.
So shall I stop sharing my screen, if I can work that out?
Yep.
Stop share.
Yes.
Okay. So yeah, there's evidence. There's some evidence to suggest, so one of the greatest times of risk is in the days after discharge from hospital. So, at about, 48, 72 hours and ongoing. So there is, concern that, could hospitalisation actually increase risk? Limited evidence that it reduces risk, but there are some people that you can't mitigate the risks sufficiently, or they may require specific treatment, that being in hospital is really important. So so certainly there is some evidence of that. So it's very much an individualised, but trying to care for people close to home in their community as much as possible would be, an ideal approach. So there's a question about First Nations Zero Suicide Prevention Working Group, which I'd love to hear more about that. It'd be great to hear what you're doing, and further information about Restorative Just and Learning Culture Framework. So there's a couple of us have engaged in partnership with the Mental Health Branch to look at how we might be able to support services across the state in embedding restorative just and learning culture. So we have got an agreement that we will put on a workshop for, starting with service leaders, because I think it's really important that we, sorry, we're running out of time, but so we're progressing that. We've got a steering committee. I'm happy, if you wanted to contact me out of session, very happy to have a chat or, talk more about what resources have we got or anything. Yep. All right, I think I've run out of time.
That's great. Thank you so much. Some lovely comments around the model that you presented in the workshop today. So thank you very much for that, Kathryn.